Hello friends, I am Dr. Saf, an ICU physician. I'm working in a hospital, university hospital. I make videos on critical care stuff. In this session, we will explore the current role of static hemodynamic markers in intensive care unit. Historically, clinicians have relied on measures such as central venous pressure, pulmonary artery occlusion pressure, mean arterial pressure, and IVC diameter assessment on ultrasound to guide fluid and vasopressor therapy. Is this still the right approach? Or should we change our focus? Should we shift our focus toward dynamic indicators which have been recently introduced in the last 10 years? So this discussion is aimed at advanced trainees in intensive care medicine, anesthesia, and internal medicine. So it's going to be very useful for them, and by the end of this session you should be able to define static hemodynamic monitoring parameters, describe the physiological basis and limitations of static monitoring, discuss the current evidence, integrate static measures with a broader hemodynamic assessment in your ICU patient. As always, let's start with a case presentation quickly. A 68-year-old man with septic shock and ARDS is receiving norepinephrine and low tidal volume ventilation, the protective lung ventilation. His CVP is 12 mm of mercury, MAP is 65 mm of mercury, lactate is 3.5, and ECG shows atrial fibrillation. In this case, would you use dynamic markers? If yes, why? And if you don't want to use the dynamic markers, why not? We will return to this question later. As you know, effective hemodynamic monitoring is critical in ICU. It helps guide fluid therapy precisely, ensures optimal blood volume and perfusion, and aids in deciding when to use vasoactive medications. Moreover, hemodynamic assessments provide prognostic information, helping inform long-term patient management. Hemodynamic parameters are generally divided into static and dynamic categories. Static parameters capture single point measurement at a moment in time, providing information about preload, afterload, and cardiac filling pressures like LV and diastolic pressure. Dynamic parameters evaluate changes in response to interventions such as fluid boluses, passive leg raising, or natural variations in ventilation or induced ventilation in ventilation or posture, offering further insight into cardiovascular reserve. Common static parameters include CVP, PaOP, MAP, IVC diameter by ultrasound. However, these parameters are poor in predictors of fluid responsiveness because they are influenced by factors like ventilation, right heart function, and intrathoracic pressure. So these are greatly influenced by these things. A meta-analysis by Marik et al. Found that CVP was unable to predict fluid responsiveness was no better than a chance of flipping a coin with an area under curve of only 0.56. So the probability was either 50% yes or 50% no. PaOP, while sometimes used, require invasive pulmonary artery catheterization, a procedure associated with risks such as cardiac arrhythmias, infections, and even pulmonary artery rupture. And it requires definitely a great expertise. Not everybody can insert the PAC. MAP does not necessarily reflect a microcirculatory perfusion. Organs can auto-regulate their blood flow, so patients may have normal MAP values and still experience tissue hypoxia. So MAP is again not a very good. One modern static measure, IVC diameter, behaves much like CVP and is likewise affected by ventilation and right-sided heart pressures. The collapsibility index is more informative than a static diameter alone. Relying solely on static measurements increases the risk of fluid overload and adverse outcomes, whereas dynamic indices such as passive leg raise, stroke volume variation, and IVC variability have become more reliable tools and standard tools for assessing fluid responsiveness, reducing the dependence on static measures in the last 10 to 20 years. And also, as we have discussed, that evidence is there to show that CVP and similar static indicators are quite unreliable for guiding the fluid therapy after 2008 in a paper published by Marik. The question is, are static measures obsolete in today's ICU practice as hemodynamic monitors? The answer is no. Dynamic assessments provide valuable information, definitely, but static measurements are still useful, especially for monitoring trends over time. They offer essential context when combined with the clinical information the clinical examination and echocardiography, the bedside echocardiography, and are particularly important when dynamic tests cannot be performed reliably. Here we can take an example. In patients with atrial fibrillation on low tidal volume ventilation, as we discussed in the initially in a case where dynamic indices may not be accurate, trends in CVP, MAP, lactate and echo findings guide the management decisions. Instead of focusing on single CVP or POP values, it is better to observe trends and changes following intervention. And as we know, meta-analysis such as the pivotal 2008 study by Marek, the Paul A. Marek et al. Have confirmed a limited predictive value of CVP for fluid responsiveness. You know, the fluid responsiveness means that the bolus of fluid is going to improve the stroke volume by up to 10 to 15%. So this is not going to happen with the static markers. So key takeaways from this video session could be as follows. So static measures alone are unreliable for predicting the fluid responsiveness. They are best used as adjuncts within an integrated multimodal assessment, including clinical judgment and echocardiography and some dynamic markers also. So if you combine all of them, you will get better picture of the volume status and you will be able to predict the fluid responsiveness better. So to close this session, here we have 3 quiz questions for you to be displayed for 2 minutes. Please share your answers in the comments. If you enjoyed this video, if this video was useful for you, please like and subscribe and let me know that what topics you would like to covered next. So that's all for